Okay. Can I start?
Yes.
Okay. Good morning, everyone. Myself, Dr. Nilesh Kumar Kucha. I am a radiation oncologist, assistant professor in GCRI, BCCRI, located in Sarti Hospital and managed by the Gujarat Cancer Research Institute, the GCRI, which is located at Ahmedabad. And I'm here to take a introduction, and I'm here. We are here for celebration of World Hospice Day and Palliative Care Day. So let me introduce and let me request Dr. Chinmay Shah sir, who is a medical superintendent at Sarti Hospital. Sir, can you give a few words? Can you say a few words for this lecture and awareness?
Thank you, Dr. Kucha, and thank you, Dr. Varun, for taking this initiative. As today is a World Hospice Care Day, actually, we can say this is a very emerging branch, and very less people are aware of. Even we can say doctors are very less aware regarding palliative care and hospice care. So this is very good initiative by both of you and Bhavnagar Cancer Care affiliated with the GCRI. So I think with this session, we will be able to enlighten all the healthcare professionals, not only doctors, but nursing staff and all other people, that what is basically palliative care. Because in India, we are uh, very emotional people, and it is very difficult to convince people to go for palliative care, even to the best of a consultant. So thank you, Dr. Varun, for taking this initiative. And I think your lecture will help us to think towards palliative care as a part of end of life care. Thank you very much. Over to you.
Okay, sir. So let me first give some information about GCRI Hospital and GCRI, BCCRI and Sarti Hospital. So here at Bhavnagar, we have GCRI, BCCRI, which is a cancer care hospital in Bhavnagar, which is located in Sarti Hospital campus. Also, which is managed by Gujarat Cancer Research Institute. So in Ahmedabad, Gujarat Cancer Research Institute has two other satellite center, like Sidhpur. There is one Sidhpur and one Rajkot, and also there is a hospice care center which is located in Vasna. So also Dr. Varun Yadav will give detail about that. And here at GCRI, BCCRI, Cancer Care Hospital, also of Sarati Hospital, we are treating all the patients, most of the patients for radiotherapy, medical oncology, chemotherapy, and surgical onco with the help of Sarti Hospital and support of Sarti Hospital. So now there is one department also started by. So I will introduce Dr. Varun Yadav, who is palliative medicine. Palliative medicine in GCRI and who is assistant professor at GCRI. Sir.
Good morning, everyone. Myself, Dr. Varun. I am assistant professor at Palliative Medicine Department in GCRI, BCCRI, Bhavnagar. Today, we will talk about what is palliative and hospice care. So, share taking.
We are audible, right, sir?
Today is 12th October and every second Saturday of the October month is celebrated as World Hospice and the Palliative Care Day. This year's theme is 10 years since the resolution and how are we doing. We will discuss this theme later on. But first, we start with some basic history of the palliative medicine, palliative care and hospice care, that how this branch and this subject is started. So first of all, we talk about the Dame Cicely Saunders, who is a founder of the modern hospice concept. And without the Cicely's unusual career pathway, it might never be started. So Dame Cicely Saunders initially started her study at the Oxford University in 1938 to study the politics, philosophy, and economics. But at that time, Second World War started, and she have to left there her study, and then she started as training in the nursing school at the St. Thomas Hospital in the London. But due to some issue, she cannot complete that, and once again she joined the Oxford University to finish her previous degree. After her degree completion, she started as a medical social worker at the St. Thomas Hospital in 1947. During that time, David Tasma, who came to the England shortly before the war break out, he reside at that place and diagnosed with advanced stage of the cancer. And at that time, no one of their family member is with him to मतलब कि उसकी देखभाल करने के लिए उधर कोई था नहीं तब डेम सिस्ली सौंडर ने उनकी डेथ तक उनकी देखभाल की देन शी स्टार्टेड वॉलंटियरिंग एज अ सेंट ल्यूक्स हॉस्पिटल फॉर द एडवांस केसेस इन दी लंदन so basically Dame Cicely Saunders started work with terminally and advanced illness patient at then St. Thomas Hospital and St. Luke Hospital and she make an interest in the treating this patient that how they are suffering, what are their problems, what problems we can solve for them. Then she started as a medical secretary to Norman Pesty Barrett, who is a consultant thoracic surgeon. And she discussed this observation that she did during the St. Luke and St. Thomas Hospital for terminally and chronically ill patient. And then this thoracic surgeon advised her to get a medical degree. If she want to do something about this kind of the patient, she need the medical degree to change something. So she began training as a doctor in 1951 once again at the St. Thomas Hospital. And after completion of her medical degree, she started as a physician at the St. Hospice, Joseph Hospice, where she worked for the next 7 years. And after that, in 1967, she made her own St. Christopher's Hospice in the London, which is the first one hospice of the modern hospice concept. So, with efforts of the Dame Cicely Saunders, this hospice care with medical facility available in hospice. So the modern hospice concept is started with the efforts of the Dame Cicely Saunders. Now the second one, which is very important for this palliative care and the hospice care is Dr. Balfour Mount. He is a founding director of the Royal Victoria Hospital in palliative care service and considered the father of the palliative care. Dr. Balfour Mount visited and undertaken a review of the care of the dying patient at St. Christopher Hospice. जैसे ही 1967 में Dame Cicely Saunders started hospice, he visited that hospice and did at that hospice and how they can manage, how they hospice, and he want to develop a way of bringing the hospice care into the hospital setting. So after completion of his observership at the St. Christopher Hospice, he started a pilot project at her own hospital, Royal Victoria Hospital, in hospital-based palliative care and introduced the term palliative care first time, which is introduced by Dr. Balfour Mount. So the hospital's palliative care service was the first of its kind at Royal Victoria Hospital. So this is the basic history how the hospice care and palliative care started by the medical field. Then after United Nation Committee on the Economic, Social and Cultural Right adopted the General Comment number 14. This comment asserted that the right to attention and the care for the chronically and terminally ill persons, sparing them avoidable pain and enabling them to die with the dignity. So in 2000, United Nations stated about the care for the chronically and terminally ill person. And after that, major resolution came by the WHO in 2014, which is in May 2014, the World Health Assembly Resolution 67.19, which is called for the palliative care to be strengthened as a component of the comprehensive care throughout the life course. So basically, the palliative care should be the part of the comprehensive care, which stated by the World Health Organization. And this was the first global resolution on palliative care and the call to integrate it into the national health policies and the national health programs, and was adopted and by the representative of the 194 member states attending the Geneva meeting. So that World Health Organization resolution 2014 completed the 10 years. So this year's theme, which is let's talk about the Indian history of the palliative medicine. The India has his first modern hospice is Shanti Avedna Sadan, which is the first modern hospice in the India and established in the 1986 in the Mumbai. And Dr. L.J. D'Souza, who is oncosurgeon who had an exposure in palliative care, was the key person behind this initiative. After that, Indian Association of the Palliative Care, which is the umbrella organization, was registered as a national organization in 1994. And after that, from 2020, the 12 postgraduate courses for the MD Palliative Medicine started from the TMS Mumbai. Now we talk about the palliative medicine. So what is the definition of palliative medicine? It is an approach which improves the quality of life of the patient with life-threatening illness and their families through the prevention and the relief of the suffering by means of the early identification, impeccable assessment, and the treatment of pain and other problems like physical, psychosocial, and spiritual. So basically, patient and their family members, the patient who are suffering from this life-threatening illness, we have to reduce their suffering. We have to relieve their suffering by early identification and total assessment and treatment of the symptom of physical, psychological, social, and spiritual. So what are the principles of the palliative medicine? So to provide the relief from the pain and other distressing symptoms, affirms the life and regard the dying as a normal process. Palliative medicine intends neither to hasten or nor to postpone the death. So we are not hasten the death or not postpone like some people asking for the euthanasia or some kind of that. But palliative medicine is not providing any type of the treatment which hasten the death or any treatment which postpone the death. Then integrate the psychological and spiritual aspect of the patient care and offers a support system to the patient to live as actively as possible until the death. And this will enhance the quality of life and may also positively influence the course of the illness. Palliative medicine is applicable early in the course of the illness, not at the terminal stage, but we have to start this as possible as early in conjunction with the other therapies which are intended to prolong the life like chemotherapy, radiation therapy or dialysis or any disease modifying treatment which include those investigations needed to better understand and manage the distressing clinical complication. It also offers a support system to the family members, their caregivers to how they cope during the patient's illness in their own bereavement, and uses a team approach to address the need of the patient and their families, including the bereavement counseling if indicated. So the team approach is advocated like multidisciplinary team, which involve the physician, nursing staff, dietitian, counselor, psychologist, social worker, whichever possible we can give to the patients. So first question is palliative care and hospice care is for which patient, for who this treatment needs. So for the advance of the metastatic cancer, chronic kidney disease patient, chronic liver disease patient, chronic lung conditions, neurological conditions, chronic heart conditions, HIV/AIDS patient, multiple pediatric condition like genetic abnormality or cerebral palsy, that kind of the condition. Many geriatric patient which with varying comorbidities, which who are suffering from the various distressing symptoms. What is the need of the palliative care? Globally, think that each year an estimated 56.8 million people, including 25 million people in the last year of life, need the palliative care. But worldwide, only about the 14% people who need the palliative care currently receive it. And let's talk about the Indian data says that only 1 to 2%, which is very less amount. So 1 to 2% of the population who need the palliative care have access to it in India compared to the global average of the 40%. According to the Health Minister data analysis, which is released by the FICCI. Now the question is when to start the palliative care. There is a myth that palliative care is given to the end of life, like at the terminal stage, but it is not like that. The palliative care, which is shown in this figure, started as the diagnosis of any chronic terminal illness is detected. So at the time of the diagnosis, palliative care and the therapy or treatment to modify the disease start both simultaneously. As the life prolong and disease advance in their condition, the role of the disease modifying therapy become less and the palliative care become more. And when there is a time life expectancy of less than 6 months, uh, hospice care started, and after death of the patient, bereavement care is also provided. Focus care changes over the time as the disease progresses, and the patient may be relatively well while therapy is underway. This figure also showing the supportive. At the early stage of disease, palliative care which is provided is termed as the supportive care. After that, it is palliative care in advanced condition. When the life expectancy is less than 6 months, it is converted to the hospice care, and the patient also should be shifted to the hospice. And after that, support to the patient's family member and their near ones. So what is supportive care? Supportive care helps the patient and their families to cope with their disease and treatment from the pre-diagnosis through the process of the diagnosis and treatment to cure the state of being ill or the death and to the bereavement. It helps the patient to maximize the benefit of the treatment and to live as best as possible with the effect of the disease, and is given equal priority alongside the diagnosis and the treatment. So concurrently with disease modifying treatment, it's help to support the patient and the family member. What is hospice care? It is a special kind of the care which focus on the person's quality of life and dignity as they are near the end of life. So this is basically what the people think palliative care is at the end of life, but it is not the palliative, it is the hospice care when the life expectancy is less than 6 months. And there are various criteria to the for the every disease, like for chronic liver disease, for chronic kidney disease, for Parkinson's disease, for dementia, for lung condition, for HIV/AIDS. Like what are the criteria to shift the patient to the hospice care? What is the end of life care? It is an important part of the palliative care and usually refers to the management of the patient during their last few days, weeks, or the month of the life, from a point at which it becomes clear that the patient is in a progressive state of the decline. It should help the patient live as well as possible until the death and die with dignity. And patient have the right to express their wish and preference for the type and place of the death. In 2014, IAPC, Indian Association of Palliative Care, published a position statement for the care of the dying patient, that palliative care is a human right and that every individual has a right to good, peaceful, and dignified death. And India ranks 67 out of the 80 countries which were studied the quality of death index. So we are very behind in this 80 country list. 67th rank is much more. So we have to improve the quality of death index. Now, next is what is the total pain? Dame Cicely Saunders coined the term total pain used when physical, psychosocial, spiritual distress combine to affect the patient. So physically unrelieved pain, other physical symptoms, undesirable effect of disease and treatment, insomnia and chronic fatigue. In social component, worries about the family, finance, loss to income, loss of the social role, loss of the role in the family, and feeling of the isolation. In emotional component, anger at the delays in the diagnosis or anger at the God, anger at therapeutic failure, disfigurement, fear of the pain, death, feeling of the helplessness. And in spiritual component, what is the point of all this? Why has this happened to me? Is the God punishing me or is there any purpose in the life? These are the concerns on this spiritual component. So this figure showing the total pain concept, physical, psychological, social, spiritual, why me, social stigma, anxiety, and physical pain. This is also the one figure showing the total pain management when standard disease directed treatment alone, and if it is added with the palliative care, this we can improve to the patient like their physical, psychological, social, and spiritual need alongside this treatment part. So we can add the life to their remaining days with the help of the palliative care. This is also one figure showing the palliative care, how can reduce the physical distress. This 10 components: sleep disturbance, poor appetite, anxiety, drowsiness, pain, breathlessness, fatigue, depression, vomiting, nausea, and poor well-being. So with this multi-component like total pain concept, palliative care can reduce the suffering for this chronically and terminally ill patient. Then the four ethics of the palliative medicine. One is autonomy, beneficence, non-maleficence, and justice. So autonomy is an expression of the informed choice and preference of the consent to whatever we do or is done to by other. It acknowledges the patient's right to know about the diagnosis, to know about the detail of the treatment offered to him, and right to refuse the treatment. So patient's choice, autonomy means basically patient want to know, if patient want to know diagnosis, we have them the what is their present condition. Then beneficence. It means that whatever one does to the patient should be for the good of that patient. Non-maleficence. It means one should not any harm to the patient while caring for or treating the patient. And justice is the principle of the fair use of the available resources. The resources are limited and the demands are high. So it concerns with balancing the individual need with those of the society. We have to use the available resources in justifiable manner. So it can be reached to the patients who is necessarily need for that. Next one, which is also important in palliative care, is palliative sedation. Before talk about the palliative sedation, we have to talk about the refractory symptom. So the term refractory can be applied to the symptoms which cannot be adequately controlled despite aggressive efforts to identify a tolerable therapy that does not compromise the consciousness. मतलब कि कोई भी ऐसी कंडीशन जिसमें नॉर्मली स्टैंडर्ड थेरेपी के देने के बाद भी अगर वो सिम्टम हम कम नहीं कर पाते हैं, then it become a refractory symptoms, and palliative sedation is used to reduce the suffering from that refractory symptom. So palliative sedation is monitored use of the medication intended to induce varying degree of the unconsciousness to induce a state of the decreased or absent awareness in order to relieve the burden of otherwise intractable suffering. So ideally standard treatment देने के बाद भी जब भी कोई सिम्टम ऐसे टर्मिनल पेशेंट के अंदर हम कम नहीं कर पाते तो एक पैलिएटिव सेडेशन से हम उसके सफरिंग को कम कर सकते हैं. The intent is to provide the adequate relief. And what is good death? So good death is one that is free from the avoidable distress and suffering for the patient, families and caregivers. In general, accord with the patients and families' wishes and reasonably consistent with clinical, cultural and ethical standard. So avoidable distress and suffering we have to reduce at the end of their life. And he can be stay in that clinical, cultural and ethical standard reasonably. One major part of palliative care is advanced care planning, a process that supports the adult at any age of the health in understand and share their personal value and life goal and preferences regarding the future of the medical care. Advance directive is a statement which is made by a person with decision-making capacity, stating that his or her wishes regarding how to be treated or not treated at a stage when he or she lost such a capacity. मतलब कि जब फ्यूचर में ऐसी कोई कंडीशन जिसमें जब वो पेशेंट खुद का डिसीजन लेने के लिए कैपेबल ना हो, तब कौन सी ट्रीटमेंट उसके प्रेफरेंस में होगी, उसका स्टेटमेंट वो before in advance they can make. So this advance directive person can make their statement. One very important article Supreme Court of India declared regarding this advanced care planning is article number 21, right to die with dignity. And this on Friday, March 9, 2018, the 5-judge Constitution of India said by Deepak Mishra stated this article and stated that legal recognition of advanced medical directive of the legal. And this article stated the right to life, which include also the right to die with dignity. And recently in 2023, recent amendment made by Supreme Court for advanced directive and a constitutional bench of the Supreme Court headed by Justice K.M. Joseph has passed the order to making the suitable amendment to previous procedure regarding making an advanced medical directive for withholding and withdrawing of the life support treatment. And this landmark judgment is said to be game changer for the practice of the end of life care in the India. There are two key amendments in this judgment. One is advanced medical directive may now be made in front of the notary or the gazetted officer. There is no need for to concede countersigned by the magistrate. And the second one is for withdrawing of the life support. There should be two committee need to be constituted by the hospital where the patient is admitted. And these two committee decided whether the withdrawing or the withholding of the life support is justifiable or not. And there is no need for a district collector to be involved in support. So this is the basic chart flow to describe the process of the advanced directive. Patient have the, if the patient has the decision making capacity at the stage to withhold or withdraw the life sustaining treatment, then we have to keen to the patient and then we have to go according to that. One another major thing is NDPS Amendment 2014, Narcotic Drug and Psychotropic Substance Act, and
Recording stopped.